Only mode.
Well, good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Flexible Testing for Respiratory Pathogens, Cost Effectiveness and Impact on Clinician Ordering Patterns. My name is Andrew Juranen, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. Now, this webinar is designed to be interactive, and webinars work best when you are involved, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. Now, this chat box is located in the control panel on the right-hand side of your screen, and if you require any assistance, please contact me at any time by sending a message using that chat panel. And at this time, all participants are in a listen-only mode. Please note that this event will be recorded and made available to you for future download. And live audience members can apply to receive a professional acknowledgement for continuing education or PACE credit issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. Certificates for approved applications will be emailed by September 15th. And a big thanks to Nanosphere, who helped develop the content for this webinar. Nanosphere, a Luminex company, is dedicated to enhancing medicine by providing targeted molecular diagnostic tests that can lead to earlier disease detection, optimal patient treatment, and improved healthcare economics. Their platform, the VERIGENE system, enables clinicians to rapidly identify the bacteria and viruses responsible for some of the most complex, costly, and deadly infectious diseases. Currently, the VERIGENE test menu targets infections of the bloodstream, respiratory tract, and gastrointestinal tract. Now, I would like to introduce our speakers for today's webinar. Dr. Robin Chamberlain received her PhD from the University of North Carolina School of Medicine in 2008 and completed a fellowship with the Department of Pathology and Immunology at the Washington University School of Medicine between 2009 and 2011. Dr. Chamberlain is currently an assistant professor in the Department of Pathology and director of the Microbiology Laboratory at the St. Louis University Hospital. Dr. Chamberlain's research interests include antimicrobial resistance in Staphylococcus aureus, as well as bacterial toxins and their interaction with the host innate immune system, particularly in the setting of Staphylococcus aureus necrotizing pneumonia. And as a clinical laboratory scientist, Marilyn Mitchell has had the opportunity to spend her early career in chemistry and hematology, and the last 20 years specializing in microbiology and molecular biology. In 2000, she completed a master's degree in molecular biology from California State University, Fresno. Over the last 10 years, Marilyn has been published in the Journal of Clinical Microbiology 2 times. Since 2012, she has been the hematology instructor at California State University, Fresno, to help prospective clinical laboratory scientists get a solid background in a needed requirement. Now, currently, Marilyn is microbiology supervisor at Community Regional Medical Center in Fresno, California, where her focus is providing physicians with correct results as quickly as possible to improve patient care. And now it's with my pleasure to hand the presentation and the microphone over to your first speaker for today, and that's Dr. Robin Chamberlain. Dr. Chamberlain, presentation's ready for you.
Thank you, Andrew, for that introduction and for the opportunity to discuss our implementation of respiratory viral testing. So I wanted to start out by telling you a little bit about St. Louis University Hospital. We're a 356-bed academic hospital affiliated with the St. Louis University School of Medicine. For the past year, we've been part of the SSM St. Louis network. So that includes us, Cardinal Glennon Children's Hospital, which is right next door, and 6 community hospitals throughout the St. Louis area. We're a tertiary and quaternary care center. We provide level 1 trauma center services for Missouri and Illinois. We also provide solid organ transplant, including lung, kidney, pancreas, liver, bone, and cornea. And we're the home of the region's only outpatient bone marrow transplant center. This allows patients to receive their care during the day at our cancer center, but then return home at night to their homes rather than facing a lengthy inpatient hospital stay. So we're not a large hospital, but we do have a very complex patient group that we see here. So this is a little bit about our lab. We have 8 full-time medical technologists in our lab and 1.5 full-time medical lab assistants. We're staffed with microbiology techs from 6 a.m. to midnight, and then overnight we have core lab coverage taking care of gram stains, pulling positive blood cultures, and that sort of thing. We do about 8,000 tests a month, and that consists of aerobic and anaerobic bacteriology, fungal cultures, acid-fast cultures, and some limited parasitology like Cryptosporidium and Giardia DFA, and blood parasite smears. Most of the molecular testing that we perform here is actually done in the pathology department molecular diagnostics lab, and a lot of that is in support of our transplant services. So we do a lot of testing for CMV, EBV, BK, and other viral pathogens, and also in support of our GI service. So we do a lot of hepatitis C viral load and genotype testing. The testing that we've chosen to bring into our hospital microbiology lab is really determined by how quickly those results are needed versus can they be batched and performed in the molecular lab, on the complexity and need for things like extraction or sample processing, on whether there are FDA-approved tests available. So the tests that we've chosen to bring into the hospital microlab at this point are C. difficile testing, rapid identification from positive blood cultures, and respiratory viral testing. So I think we're all familiar with some of the things that have been changing over the last few years in the microbiology world. One of those things, I think, is our role in antibiotic stewardship. So we're more and more being called on to work with our antibiotic stewardship teams and provide results to them that can expedite appropriate drug choices more quickly for patients. Some of the other things we've seen is a transition from conventional virology labs to molecular methods for testing for viruses. So we've seen a decrease in the number of labs who are doing viral culture and an increase in labs performing molecular testing in microbiology. It's getting more and more difficult, a lot of us are experiencing, to find medical technologists, so those jobs are harder to fill, and in many cases we're working short-staffed or with techs who are working on double benches in a day. There's increasing regulation of laboratory-developed tests, so a lot of us are really looking for FDA-approved, reliable quality tests that we can perform in our labs. And we're entering an era of value-based reimbursement. So rather than looking at how much lab testing we can do, we really want to look at providing the best testing for our patients. Some of the specific things we looked at as far as respiratory viral testing goes is that with respiratory viruses, because the symptoms are so nonspecific and the seasons can be overlapping, decisions regarding patient management and infection prevention can be really challenging. So we knew that we needed to be able to test for a variety of different viruses. And we know that delays in diagnosis of those viruses, not being able to quickly provide the identification, can lead to increased testing and treatment, so additional imaging, additional antibiotic use, and there are costs and risks associated with that. I wanted to tell you a little bit about our approach in the past to viral testing, and I'm kind of going to divide that into how our bone marrow transplant team approached that versus our inpatient team, because they had a little bit different way that they looked at this testing. So when I came to St. Louis University Hospital 5 years ago, we were not performing any molecular testing in the microbiology lab. We were doing rapid flu antigen testing as our only respiratory viral test in-house, and viral cultures were sent out to a reference lab. So over time, we shifted from sending out viral cultures to sending out multiplex molecular testing, but it was still going to a reference lab. So even though that test itself may be very fast, the time it took for that sample to get across the country and be tested and results to come back was taking 3 to 5 days. So even though there was this increased sensitivity and additional organisms that had been difficult to detect in culture, we still weren't really getting what we needed. And a lot of our physicians practice at other hospitals, and so they were experiencing in other places getting that rapid result back right away, and we're really dissatisfied with what they were experiencing here. For our BMT team, their threshold for testing patients for respiratory viruses is very low. So in those patients, a diagnosis of flu or RSV can have up to a 50% mortality rate, and the hospital cost for hospitalization with one of those viruses can approach what the cost of the transplant originally was. So they're very cognizant of these risks, and they stay on top of this testing. So they were routinely sending out their testing for respiratory viral molecular detection, and were very vocal that they needed a better way to get that result back. Our inpatients were a little bit different story. A lot of them were getting rapid influenza antigen testing, which we know is fast, but we also know has very poor sensitivity. And then they had the option of follow-up that we just described for the BMT patients, in which they initially could have gone out for viral culture and then later could have gone out for multiplex molecular testing as that became available. But what we saw was that they very rarely offered either of those follow-up tests. And that was because clinical decisions really couldn't wait until they got those results back, and so they saw that result as not very useful. They were going to have proceeded with whatever they were going to do with that patient long before we knew that answer. So our decision to evaluate molecular testing in our hospital was really driven by two things. One is that obvious dissatisfaction from our physicians with turnaround time, and the other was really antibiotic stewardship. So initially this was in the area of positive blood cultures. There was a motivation to decrease long-term use of broad-spectrum antimicrobials and to be able to get actionable information 1 to 2 days earlier that allowed physicians to narrow treatment. And so this was a win-win of offering better treatment and potentially decreasing cost of overall care, though we still need better data to show that that's really what we're able to do when we give this faster answers. And then we saw how that could also be extended to respiratory viral testing. If we could prevent that additional treatment and diagnostic testing by quickly knowing what the respiratory infection was, that should also aid in our antibiotic stewardship efforts. So some of the factors we looked at when we were choosing what platform to bring in, we had periods of understaffing and, as I mentioned before, difficulty hiring techs. And the staff that we had in the lab had limited molecular experience. So we really needed something that didn't require extraction steps or a lot of hands-on time, something that could easily be incorporated into the workflow and that was FDA approved and not a lab-developed test. We didn't want to add complex testing to people who were already working very hard to do the testing they had been doing. So we wanted a platform that offered us the option to expand testing in areas that interested us in the future, such as testing for GI pathogens. And then primarily our real interest was in saving some money. That send-out respiratory viral panel that we were ordering, we were paying $555 for each time we sent it out. So at the time we were making this decision, our hospital was in an extended process of being sold. So the slide I showed you of my lab, you probably noticed that some of those instruments haven't been purchased recently. So we are still doing biochemical identification of organisms. Right now we're still using BACTEC 9000 series blood culture instruments, which will actually be replaced within the next month. But because we hadn't really upgraded instrumentation in a while. And so we knew that we were in a situation where we weren't likely to get multiple platforms approved for purchase. And so we'd need to be as flexible and efficient as we could. So the cost of the platform was a consideration, but really our main consideration cost-wise was reagent usage. So being able to customize the testing to our needs so we weren't paying for testing we didn't need was really important. Also, the ability to start with limited testing and then follow that either immediately or later with additional results without having to do additional work was very appealing. So I'm going to just briefly touch on what targets are available. on the RP Flex because I think Marilyn's going to go into the targets and the pricing a little bit more during her talk. But as you can see, it offers influenza A with subtyping, influenza B, RSV A and B, parainfluenza 1 through 4, rhinovirus, adenovirus, human metapneumovirus, and several different species of Bordetella testing. So the RP Flex pricing is divided into groups, and again, I'll just touch on this. But there's a base price when you reveal the results for the first group, and then for each additional group that you access the results for, you're charged a usage price. So you can really just see one group and pay a very low price, but then if you need to see the rest of it, then you can reveal those other results as needed. So the way we chose to set this up in our hospital was to build 3 different panels. So the first of these is flu and RSV. The reason that we, let me go ahead and show you what the panels are. So we did a flu RSV panel, a complete respiratory viral panel, which is everything here from flu on down through human metapneumovirus, and then a Bordetella panel. The reason we chose those 3 panels, we worked together with our infectious disease team and our bone marrow transplant team, and we initially thought we would offer flu as a standalone test, that would be the most useful, but during the time that we were waiting for FDA approval of this test, we used the flu RSV cartridge for a while. And what we found was that we had more RSV in our population than we had expected, and our doctors were really interested in being able to continue seeing that result. So the way that we split this up then was flu RSV or a complete respiratory viral panel or Bordetella. So we saw the physician feedback that they wanted the flu and RSV. Then we saw the next step is really that comprehensive panel rather than breaking it into multiple different options because of the overlapping symptoms and seasonality of respiratory viruses, and because of our really vulnerable population, we felt like if it wasn't flu RSV, we needed to be able to see the whole panel. So that allowed us to offer a few different things, a fairly low-priced flu RSV, a full respiratory viral panel that then included the base price plus 3 additional groups, or the standalone Bordetella testing. A little bit about our testing process. We offer those 3 separate orders. Our electronic health record is Epic, and our LIS is Beaker, so we had those built into Epic. Some limitations on our testing. We don't offer the testing for outpatients other than in our bone marrow transplant clinic. We don't offer the testing for the emergency department unless the patient is being admitted, except for Bordetella. We do allow Bordetella to be done in the outpatient setting because we thought that made a lot of sense for people who may be seeing the physician with concerns about pertussis. The other thing that we had to do here was when we reflexed to the full respiratory viral panel, we were unable to get Epic to know how to handle that really as far as billing. So we have to manually go in and generate a credit for the flu RSV testing so that our patient doesn't get billed twice. So that's maybe something you could work around in a different system, but so far that's been a limitation with our system that we haven't quite figured out how to handle yet. I want to look at some specific data. So this is CDC numbers for this past flu season, which you're all probably pretty familiar with. And then if I superimpose our peak season here, you can see that it coincides really well with what the CDC reported. Our peak was really mid-February to mid-March, and we primarily saw H1. So that kind of went along with what was shown nationally. And then I'm going to show you how we actually use the VERIGENE test in our hospital during this flu season. So this is our usage data. The first bar is the flu RSV testing. The second bar is the complete panel. And the third bar is Bordetella. We went live in mid-January, so I'm showing you from February through July. And so at initial inspection, it looks like we were going directly to the RVP the majority of the time and not really utilizing that flex advantage. But what we realized on inspecting this further was that most of our patients are coming in through the ED, other than the BMT, who are always getting the complete profile. Our patients coming in through the ED are still getting the rapid flu antigen first. part of that is we're not staffed overnight for molecular testing purposes, and also just the really fast turnaround of a rapid flu. So while we know it's not very good, it lets the ED get some quick data. We're hoping by next flu season that we're going to have replaced our rapid flu antigen with a better performing fast test. But what we realized once we factored in the fact that people were testing for flu in a couple of different ways was if we looked at any flu test, so that's rapid or the VERIGENE test, we saw that we performed more of those than we performed the respiratory viral panel alone. So everybody's not getting a respiratory viral panel. The other thing that we saw when I looked into these patients individually is that they're kind of a split between our bone marrow transplant patients and ICU patients. So these are really sick patients, which gave us confidence that the test isn't being overused or misused, that these are people in whom this test was necessary. And then I want to look quickly at some cost analysis. So our cost to do the complete profile using the VERIGENE is about $100 per test. That's the reagent cost. So for the 726 tests we've performed since we went live, the cost of that in reagent would be $72,600. If we had sent those all out to our reference lab, that would have come up to almost $400,000. So it's important to point out that we wouldn't have sent those all to our reference lab. As I mentioned earlier, with our inpatients, the physicians were just kind of skipping that because the results were not coming to them in a usable time frame. But now we're able to have that information at a far lower cost than we would have had using our previous testing methodologies. So a few of the challenges that we have faced since the implementation are how to follow up with these bone marrow transplant patients who are positive, because they're going to stay positive for a while, and we're not sure what that result means or how to use it, but our physicians want to keep doing the test. So we're still really trying to figure out what that means and how to use that result in that case. Another challenge that's also an opportunity is we're very quickly now learning results that should require a patient to be isolated, and we don't have a system in place that's letting us do that as rapidly and efficiently as we should. So that's something we're working on now. We'd like for our LIS and EHR to be a little more nimble with how to manage these reflexive add-on orders and the billing that goes with them. And we'd like to be able to further modify and allow multiple ordering options, especially other types of infections. I'll just finish out by talking about our interest in a multiplex enteric panel and how we see this working well in a flexible testing system. So we'd like to be able to select targets for GI testing based on things like the patient's clinical presentation, their travel history, their age, whether they're immune compromised, and things like whether they have, they're positive for fecal leukocytes or transferrin. Lactoferrin. And then we'd like to be able to test for a wide range of targets, but not on every patient. So we'd like to be able to test for the common bacteria that we look for in stool culture right now. We'd like to be able to look for Shiga toxin. We'd like to look for C. diff toxin when that's the appropriate thing to look for. We'd like to look for some of these viruses that we know are the most common cause of gastroenteritis in the community. And then when we need to look for parasites, we'd like to be able to start with Cryptosporidium and Giardia, or when it's appropriate for our patient to look for some of these other less common parasites. So what we can envision doing with the ability to reflexively test for GI pathogens is to create panels and to use those to address things like nosocomial infections, community-acquired infections, persistent diarrhea, and get the right set of targets so that we're keeping the cost reasonable and also not just taking a shotgun approach and testing for everything, which we all know the troubles that can come for that if you're testing in a low prevalence population, or if you're testing for C. diff in the patient who you don't think has C. diff infection, especially in an era where we're having to report those numbers if they could be nosocomial infections, and that's affecting our reimbursement rate. So we really want to be able to tailor this to the right set of tests for our patient. So with that, I'm going to stop for now and transition this over to Marilyn. Marilyn, go ahead.
Thanks very much, Dr. Chamberlain. I appreciate that information. Very good. So So my name is Marilyn Mitchell. I'm the microbiology molecular supervisor for community medical centers in Central California. That is actually specifically in Fresno. So I'll be talking to you about some of the thought processes that we went through to see if that RP Flex panel would be cost effective in our hospital system. And then
Marilyn, if I could just interrupt for 1 second, could you accept that pop-up? We're not seeing your screen right this second.
Did that do it?
Yeah, that did it. Thank you.
Very good. Okay. So, yeah, we're on that, the title screen here. So, and we're talking about whether that would be a good test for us, be cost effective, and if we offered it, would it affect our physician ordering patterns? So our hospital system, we're a large community hospital system actually in California, and we have 3 acute care hospitals in the system. Our total bed capacity is over 1,000 beds, and we are a training hospital that's closely associated with UCSF. The flagship hospital, Community Regional Medical Center, is where most of the microbiology is performed. And we have the second busiest emergency room in California. So that includes a level 1 trauma center. So in addition, we have several different specialties here involving cardiology. We have an active burn center and orthopedics, and we are expanding in pediatrics and neonatal care also. So we're the safety net hospital here for the county, and we treat a lot of patients that have not had prior medical care. So our physicians and our hospital administrators know that there are a lot of challenges to moving patients through our system. So what we're trying to do is make their life easier by helping them address some of the possible ways of improving things. So we know that what we want to provide is answers to the questions that they have, such as what would be the kind of testing that would be a positive impact on our patient care. It would maybe treat patients faster and with the right treatment, whether or not the antibiotics were appropriate, and if some medication is appropriate, then switching at some point to the oral antibiotics or medication instead of IV. So then we want to make sure that we are offering a really accurate lab result and altogether provide treatment so that the patient would recover more quickly. In addition, we felt we should give information on whether or not a test is cost effective. So we want it cost effective for the patient, so they're not charged extra things that the physician didn't really think was needed. And for the laboratory, it's expensive on some of those larger panels. So we wanted something cost effective for us and something that doesn't take a lot of hands-on time, because cultures or viral cultures, some of those things take a lot of hands-on time to get the information. Also, is it cost effective for the hospital overall? So those were some of the things that we are looking at. So it needs to be easy to perform and fit efficiently into our workflow, because we wanted multiple shifts to be able to perform this testing. We're always faced with staffing issues these days, and I think that's probably all over the country. Dr. Chamberlain mentioned that also. So we have a lot of retiring licensed CLSs, especially in microbiology, we've noticed that, and we have an always increasing workload. So we want to make sure that we're making the best use of our CLS's expertise and training, and make sure that if there is an automated method out there and a molecular method that would improve our processes and be efficient and provide really good results, then that may be something that we should look at closely to see if it would work into our hospital lab. So we wanted to be able to involve our CLSs into some of the other things where we could really use their expertise and have them participate in and really lead out in a lot of the new method validation or verification, and help with competency monitoring and training. All of those issues are always big as we are retiring some CLSs and getting new people. As we were looking at some of the systems available, we were looking at what some of the multiplex products are. The ones that we looked at first all had fixed panels, and they had fixed costs. So if you purchased the panel, there was no flexibility if they wanted just one test off of the panel. So the physician ordering preference is based on clinical presentation and some of the local seasonal epidemiology considerations. So some of the tests that we looked at, first of all, we were using molecular. First was EIA, then molecular for just flu AB. And there are several different companies that have good tests for that. Then there are also fixed panels on the flu AB in combination with RSV. And then third category then is the full respiratory panel that involves a large selection of respiratory pathogens. So we were looking at a chart that kind of shows some of the patterns for what's going around. And there is a lot of overlap, as you can see, but especially during influenza season, you have a really pretty specific time frame, and RSV fits in there pretty carefully and closely also. So they're not really high the rest of the year, but we all are very familiar with influenza season, I'm sure. At least in California, we are. So some of the testing algorithms to consider and that we were considering, what we were using initially was the rapid EIA, that's for influenza and RSV, and then we would need to send out the additional testing requests. That included the viral cultures as well as adenovirus and pertussis testing, things like that. So the part that we were performing on the EIA really didn't have good sensitivity. And for the send-out test, it was a pretty long turnaround time. Plus, they were expensive. So then we looked at molecular tests that would be available at that time. We were able to find some that had flu A and B, and some had the RSV, some did not. We would still need to send out the additional test requests. So this gave better sensitivity on the flu and the RSV, but we still had the issue of the long turnaround time for send-out tests, and they, of course, are expensive. The other option to look at were the broad respiratory pathogen panels that has a lot of different targets. But then we would need to use that for all of our patients or offer an additional, some individual panels to go along with that. So we would have multiple platforms going on if we were to try to separate out some. But if you ordered the broad panel, you get all of those answers. So it's really a good method. It's good sensitivity, but it's expensive. And we were concerned about the cost burden to our patients and to our hospitals that are on DRG. And keep in mind, we are a safety net hospital, so we get a lot of patients that are not covered by insurance that are sometimes undocumented. So we have looked at then the Flex price broad respiratory panel, and it has good sensitivity, it's more cost efficient for us, and it can help minimize the cost burden to our patients and to the hospital. Our big concern is that we have people that are very ill with respiratory infection, and we know that we want to improve our testing capability. So in looking around, we realized that maybe one size did not fit all, and not every test needs to be done on every patient. So the RP Flex allowed us to have that variability. So we can accommodate the clinician ordering patterns that vary by season and what's going around, and also the patient demographics. So with the what's going around type thing, when school starts, what are we seeing? And that seems to vary by the month of the year. Patient demographics, sometimes it's very young patients, sometimes old, or sometimes immunocompromised, and these sometimes have different needs for testing. So we wanted our clinicians to be able to make those changes based on that. So the goals were to consolidate platforms and the assays and reduce our send-out costs. So one benefit to that we really were happy about is that you can reduce the amount of monthly QC. It's easy to keep track of inventory control. It's easier to train if you just have one platform. Your proficiency testing is easier to coordinate. Competency is easier to monitor. And all of us have worked with the IQCP and our documentation. And all of this is easier if you have consolidated your platform. So looking at costs, if you look at our middle column here, this is our data for 2014, the last year that we were using, full year, that is, that we were using the RV Plus from Nanosphere, and that includes the flu and RSV on that panel. So 2/3 of our patients, they actually ordered both tests, the flu and RSV. So, and also I will say the prices that I put on here are some of the list prices and not our specific or what your pricing would be. So then we also noticed that about 1/3 of our tests were ordered just as flu or as RSV alone and not a combination. So then we also included a column here for the pertussis that was a send-out, and it was a little over $100. So when we looked at our price for that year, it was over $200,000, almost $202,000. So our average turnaround time for a send-out test was 2 to 3 days, and for the clinical value that it presented at that point, by having some of the tests come back late, it was pretty expensive. So what we decided is that the RP Flex offered an opportunity for additional pathogen coverage in addition to the influenza and RSV. So we were able to bring in some of the tests that were sent out and eliminate some of the viral culture needs also. And then we didn't have to eliminate the targeted testing that the clinicians were requesting, but we were able to still have that broader panel when needed. This slide's a little bit busy, but maybe you can get some information from it. So the VERIGENE RP Flex offers one consumable and is one platform. It goes on the Nanosphere instrument, and then this covers that whole multiplex respiratory testing. And if we look, this is the first test or first company to offer this pay for reportable billing, which we felt was a real plus. So you can either order the individual assays, such as the flu A and B or your RSV, pertussis. Any of those you can order separately, or you can order, set up group testing and set up a viral panel that maybe has everything in it, or maybe it has everything except influenza if you want to have that as a separate test. Or you can order everything on the whole panel and get the Bordetella along with all the viruses. So the only thing, if you order just the pertussis, you only pay the base price of your reagent, which you already paid for that when you bought your kit. So there's no additional cost. So then if you add on any additional of the groups, for instance, if you add on flu or RSV or both of them onto a pertussis order, you pay the original reagent cost, which is already paid, and then you would add $20 for each of the groups that you add on to that. And for a panel, it would be the same way. The first group you've already paid for, then any additional group, it's an extra $20. And again, those are not necessarily the prices that you would pay. Those are list prices. The VERIGENE RP Flex offers 5 different groups, and each of those have several different targets. And one nice thing about the influenza, for instance, is it does have the H1 and H3 breakdown still, so that's a good help. And then the parainfluenza offers 1 through 4, so that is that's good to have that breakdown of all 4 the parainfluenza viruses, and the pertussis offers the breakdown of those various Bordetella tests. So this is kind of going over the same thing again. So each of the 5 testing categories carries a charge. You have already paid for your consumables, your cartridge. When you purchase your kit, you have already paid for that first group test. So when you add any additional group, you select those on the VERIGENE reader, and then those get billed on a monthly basis. And if that sounds confusing, it really is not. It's very easy. The data gets transferred automatically. It's already held in the VERIGENE reader, and once a month you transfer this information either through a direct network connection or you put it onto a flash drive and upload it that way. So that's really it's a lot more simple maybe than it sounds. And then once you've sent that to Nanosphere, they send you an invoice every month, and that includes the cost for all the additional targets that you tested and added on for that month. And this is kind of the same thing on a picture. So you initially purchase your test consumables, which is your amp tray, your extraction tray, and your cartridge. All of that initial setup is $50. And then your reader tracks the add-ons. You monthly transfer the data, and then you get invoiced. So it's really a pretty direct system. I wanted to include a few shots of what the screens look like. These are on the actual reader. So when you order your original test, you choose one of those 5 original categories, or you choose whatever the physician is ordering. So if they are ordering the full panel, you would just say select all, and that would order all of them. The middle one shows an actual picture of what the screen looks like on a results report, and if those were not the chosen targets to report, it's not going to show you the results. It will just say results not available. So if they call down from the floor or do an add-on test and say we want to add on, for instance, a parainfluenza, so then you would go back to you'd pull up that sample number and ask it to reveal additional targets, and then it says to confirm the target, make sure that's the one. And that gives you an option if you typed something wrong or if you clicked on the wrong thing, you do always have options to get out of that screen. So after putting in the RP Flex testing, this is actually part of our justification at the beginning. We wanted to show what it would look like if we used that Flex pricing, and we presented this as part of our justification to hospital administration too. So again, we have the 2/3 of the testing was the flu plus RSV. So it was the $50 plus an additional $20. If they ordered only the flu or the RSV testing, it would just be $50. And then the bonus testing also that we were not offering in-house before is the pertussis. And if they order that only, which often that is what they do is just want pertussis, then that cost would just be $50 instead of paying the send-out cost. So that brought our test pricing down to almost $50,000 for the year. So we reduced the turnaround time because we didn't have to worry about send-out testing. We have good sensitivity for all of our pathogens. Plus, it's cost-efficient approach where we can have accurate testing and improved selection to offer for our patients. And the cost to the patient is minimized because we are providing this on a flexible basis, and we're still offering the molecular respiratory pathogen test. One thing that we all kind of struggle with, or we all kind of moan and groan about, of course, is doing a verification for an FDA or a new test that we bring in. This test is FDA approved, so it's not as complicated as otherwise could be. So you have to follow your CAP, your state, your CLIA guidelines on this, but a little bit of guidance on this that might be helpful to some of you is, first of all, you have to make sure that you are testing for accuracy and comparing for accuracy. So you want to make sure that your new result compares with your reference method, and make sure that you do have a reference method to begin with. So the sensitivity that you are looking for in a test would be that you have no false negatives, so that if a sample is supposed to be positive, it actually is positive. And you also want to make sure you're not getting false positives, and this would be your specificity. So you'll want to include at least 10 negative samples, and then again follow your institution guidelines on that. But what you want to make sure is that you are not getting contamination. One thing that can happen, though, is your new test may be more sensitive, and so you may end up getting positives on samples that your older method did not detect. So then you would work that out to how you're going to figure out which test result is the correct answer. So you should always know what you want to do in case of a discrepancy. Precision's another thing, of course. You want to show that the test is reproducible if you have different people running a test and if you offer it at different times of day. So we chose about 5 specimens, and we did those over 4 or 5 days. We had different operators running those, and we want to make sure that we're getting correct results and the same results each time. And then in numbers 3 and 4, it's interesting. Some of the things have changed because of the IQCP that we have available. We no longer can accept the EQC. So we need to, if we want to use an IQCP, we need to do a 20-day QC to show that our onboard QC is working as well as the external QC. And then we can switch to that new lot, new shipment, or every 30-day QC. But follow what your institution says, or CAP guidelines. So what we did at our facility is we broke it down into 5 possible orders. We left several tests orderable as single tests. So you could have the flu by itself, you can do RSV by itself, adenovirus by itself, or the pertussis group by itself. And the only panel that we offer is the respiratory viral panel that does not include influenza, and then also it doesn't include the pertussis testing. And for us, this was the easiest way to work out the billing and also make it easy for ordering and to be able to get just the tests that the physicians were wanting. They can still order everything when they feel that's what they want. So one thing we noticed, and we were concerned about, would our physicians start ordering the full panels more? Because we were not getting a lot of full panel orders before. And we found that our physicians were sticking with their usual ordering practices of mainly the influenza testing was the big thing. RSV is second. As I had mentioned earlier, about a third of our patients, they were ordering both of those tests. The panels were not ordered that much. So our influenza-only orders really followed the CDC incidence of the influenza when it was going around. So we were happy to see that change. Our July influenza went back up, which is interesting. That could be that we have a lot of people that have a lot of respiratory stuff because we have, right now, there are a lot of wildfires going on around here. A lot of that air comes into the valley. So that explains some of the things going on with July, and August we probably will have that too. So this chart kind of helps show that we have a low number on our on the full panel orders. It kind of mimics that chart that I was showing you. And we can see that the average number of groups that were ordered per patient usually is pretty low, mainly that one group during flu season. As it gets into different seasons, we see more of the full panels and less of flu-only orders. So for billing and reimbursement, that's going to really depend on how you set up the test in your LIS or your hospital system. And probably each hospital is going to be different on how they set it up. And the RP Flex panel allows us to be very cost conscious, and the patients then only get billed for the tests that are that the clinician orders. And then in addition, the lab only pays for the tests that are performed. So that's kind of a win-win for everybody. So in summary, some of the things is that we have better adaptation to our physician ordering patterns. We have the flexibility to get results in a timely manner. We're able to train on one platform instead of several different ancillary tests, and that helps a lot with our quality control, purchasing, and monitoring. Also, it helps a lot with proficiency testing. As more panels are available, it makes it a lot easier to keep track of. And we have the flexibility for the patient costs and not performing some of the unnecessary tests and some times of year when it may not be necessary. So this is just kind of a cartoon. We feel either our kids or ourselves can get pretty sick sometimes with that flu, but we want to do the best we can to get back into our normal life and have that big smile on our face. So I'm ready to turn this back. That's the end of my presentation.
Fantastic. Well, thank you very much for that, Marilyn. Also, thank you to Dr. Chamberlain for her portion of the presentation. That was fantastic from both of you. At this point, I would like to invite our audience to continue sending their questions and comments in right now. The questions window for this, of course, is the Q&A portion of the webinar. And I've already received some questions here, so let's get started. Our first question here, have you seen a dramatic increase in respiratory viral panels ordered now that you both offer that testing in-house?
Well, I can
go ahead, Marilyn.
Okay. From our perspective, no, we have not seen that at our hospital over this last year. We monitored that fairly closely, and we felt that our physicians are still ordering. The majority of testing is still influenza. That was about 2/3 and 1/3 with RSV. And maybe 10% during flu season, about 10% of them were ordering the full panel. And then as the season goes, like right now, we have less of the influenza and more panel orders.
And I can say in our setting, we did see a pretty substantial increase in full panel orders. And I don't think it's an inappropriate increase. These are patients who the physicians would have liked to have tested in the past, but found it not very helpful to have a 3 to 5 day turnaround, so they just didn't do the test. So we've looked pretty closely to make sure we're not overusing the test. And we feel like the patients it's being used on here, it makes a lot of sense to do it. And also our numbers are a little skewed, like I mentioned before, because we're still doing rapid flu as our primary flu test on patients coming in through the ED. So while the majority of our molecular is the full panel, it's because a lot of them have already had their flu test by that method, and so now they're looking to test for those other viruses.
All right, well, thanks to both of you for that question. Another question here, how conscious of cost to the patient are you when making the decision to bring in a molecular respiratory panel?
That's one of the concerns that we always would want to address. A lot of our patients are covered by insurance or Medicare and some other issues like that. So we want to make sure that, and if they're private pay, we do want to make sure that we do have a reasonable cost and not charging the cost of a really big panel. So it makes it better for our patients if the doctor is just ordering the more specific testing that we can bill just for that.
And that's a major concern here as well. Like Marilyn mentioned in her talk, we're also a safety net hospital, and we do see a lot of patients here who are uninsured or underinsured, and we don't want to stick them with a huge bill. But we also weigh that against, are they likely to stay in the hospital longer, have additional diagnostic testing done that we could have curtailed by getting a fast answer. So we try to be very careful about how we balance that.
All right, excellent. Thank you both for that. Moving quickly on to another question here. Can you give us some data on read failures or invalid testing rates from your experiences? I'm sure you don't have specific data on hand there, but maybe a general answer there would be great. So for either of you.
I can say our rate here has been very low, and I'm sorry I don't have a percentage rate in front of me, but it's a very uncommon occurrence.
And I would agree with that. We don't have a lot of invalid results.
Great to hear. Okay. Moving forward to another question, what is the reimbursement rate for the multiple panels, whether ordering one test or multiple?
Marilyn, are you able to speak to that? Because I don't have the answer to that.
I can give you approximate. It depends, of course, on what CPT code you're using. And as I said earlier, each hospital is probably going to maybe have it set up a little bit differently in the panels. Even Dr. Chamberlain's hospital and our hospital will have it set up differently. So you're going to be using different CPT codes. So you have to look at what the reimbursement is for your area and for the way you set up the panel. And one thing that I think you can, possibly do is you don't have to use some of the really big panel charges on that. You may find it's might cost or be a little bit less expensive to your patients if you work out the pricing a different way. But it depends on how you want to set up those panels.
Right, okay, so a bunch to consider there. Perhaps we'll squeeze in one last question here. Do you use these panels as a stat test? And how long does it take to perform each group or panel from the time a specimen is actually received?
We don't offer this as a stat per se. Like I said, from our ED, we don't offer it unless that patient's being admitted. But it takes just a little over 2 hours to run the test, and the setup time is just a couple of minutes. So for our bone marrow transplant patients, for example, they can get this back while they're still in the clinic being seen. So while we don't offer it as stat, we run them as soon as they come into the lab during times that we have microbiology staff here. So our turnaround is at being around 2.5 hours.
We do offer this as a stat test. We don't have any other rapid influenza or RSV tests at this time. So we offer this stat for our emergency room and ICU or other areas of the hospital. So the time is, a little over 2 hours. It's very easy to set up, and we're staffed pretty close to 24/7. Weekends at night, we don't always have somebody there to do the testing, but our coverage is really pretty good for getting those test results out.
That sounds great. Maybe we'll sneak in one last question. This one for you, Robin. Why would you not offer this testing for ED patients? Would this not help providers better triage patients and determine if they need antibiotics versus an antiviral?
Sure. So I should clarify that a little. If your patient is going home, regardless of this result, then we don't think that this test is a good use of resources. If you're using this for your decision of whether to admit or not, then yes, we can run that. So when we get these ordered from the ED, which isn't a lot because our providers down there have a pretty good idea of how we use this test now, then it's really just we call them and try to better understand. We just don't want to misuse it by running an expensive test on a patient who they don't feel is sick enough to be admitted.
Right, makes sense. Well, thank you very much for that, Dr. Chamberlain. Also, thank you to Marilyn for all those answers. We have reached the end of the question and answer portion of this webinar. If we weren't able to attend to your questions today, the team at Nanosphere may try to follow up with you after the webinar. But if you do have some further questions for them, please direct your questions to the email address showing on your screen right now. That's webinar@nanosphere.us. And thank you everyone for participating in today's conference. You'll be receiving a follow-up email from X-Talks with access to the recorded archive for this event, and a survey window will be popping up on your screen. Your participation is appreciated as it'll help us improve our further webinars. Now, I'm just about to pass you a link in your chat box. You can say thanks to our speakers via Twitter using that link, so I encourage you to do so. Thanks to our speakers today, Dr. Robin Chamberlain and Marilyn Mitchell. We hope that you found this conference informative. Have a great day, everyone.